Erica. Thanks for the intro. And thank you to everyone who are taking your lunch hour to tune in today. We will be doing a fairly clinical review of the common features of GI issues or gastrointestinal problems that are kind of more common. I try to emphasize which ones crop up in kind of the lay population. And we'll also look at how to diagnose those disorders, as well as how to treat them from medical and nutritional lifestyle management. My disclosures are I am employed by Providence, and I also tend to push kind of a plant-based diet. Um, each person is unique, and what works for one person doesn't always work for another. So it's just important to be aware of our biases. I also am a big encourager of meal prepping, which can be tricky when we're busy. So why don't we launch into the gastrointestinal diseases and what to do about them? We'll be using this anatomical tom here to cover the top to bottom review of these more common ailments. And actually, I wanted to start today with a poll. So for this first question, I just want to know if anyone here has had issues with any gastrointestinal um, issues in the past. So are we seeing that poll come up? Here we go. Let's go ahead and indicate you should be able to, it should be a multiple choice that you can select as many or as few of these issues have come up before. Looks like there are some food allergies in the crowd. Reflux, another very common one. Yeah, I'm excited to dive into the lower gastrointestinal issues as well. It's like we're coming up on 40 responses. I'll just give it another moment or so to indicate if any of these issues have been a burden before. Okay, I'll go ahead and end the poll, share the results. Okay. So we'll definitely maybe cover the highlights of gastroparesis, liver, and celiac, and then make sure to hit some of these other ones in depth. Thank you all for your responses. Okay, so let's dive into food allergies. It looked like that had cropped up in our participant poll. So Up to Date, which is the clinical resource I use to put together a lot of these slides, a quote from them: there is an increasing number of patients react to multiple foods. So many people are plagued by the itchiness and hives and sneezing of food allergies. It's important to differentiate food allergies from an intolerance, which is defined as a difficulty digesting or metabolizing a particular food. Food allergies, on the other hand, are really IgE responses. So that involves widespread activation of our white blood cells to attack a perceived invader. Some allergies are outgrown, like allergies to eggs or to cow's milk, but others persist, like nuts or shellfish. How do we diagnose allergies? So the proper way truly is that we can use a RAST test, which is just detects the IgE levels in the blood. So that would be the antibodies that are responding to these. There's also a skin prick test, image featured here. However, these are good tests, but they don't stand alone. We need symptoms to confirm that diagnosis. It's important to know that there's no permanent treatment for food allergies. We can't completely cure them. However, it's best to be prepared with an EpiPen should there be an accidental allergen exposure. There's also some therapeutic treatments like monoclonal antibodies, which don't cure the allergy, but they make it a little more tolerable when we might ingest it accidentally. On the nutrition side, of course, the best thing we can do is avoid the allergen. And for people with many allergens, we may be important to supplement those vitamins or minerals that might be missing from the diet. Here's a brief look at the big 8 food allergens. And in fact, sesame was recently added, so I think we should edit that to the big 9 food allergens. These are the most common. Here's just a look at that IgE or RAST test result. So basically we come back with sheets of paper of all these potential food allergens. And you can see over here where the low numbers or underneath 0.35 is barely even registering for any allergy to rice. But then this poor individual has quite high readings for some of the other allergens. So would benefit from working with a dietitian. Let's go a little further down the GI tract. So we're really looking at the reflux here, which is characterized by heartburn and regurgitation. Often regurgitated small pieces of undigested food really characterizes these symptoms. As we saw in our poll, GERD is pretty common. So almost 1 in 3 people suffer with this condition. You may have heard of the link between reflux and a condition called Barrett's esophagus, which is basically the damage that happens in the lower part of the throat from chronic stomach acid where it's not supposed to be. And that can put us at some risk of esophageal cancer. But just because we have reflux doesn't mean we'll end up with esophageal cancer. This is usually just diagnosed from classic symptoms. But an endoscope may be indicated if we want to rule out Barrett's, as well as what they call alarm features, so any signs of potential cancer development in the lower esophagus. Fortunately, if we treat it well, we don't have to worry about these further complications. So we have these proton pump inhibitors, Prilosec and Protonix, very common to help manage these symptoms. Most people in clinic are pretty well controlled on those meds alone. Certainly, we have a slew of lifestyle interventions, avoiding trigger foods that we'll look at on the next slide, the loose-fitting clothes, avoiding smoking, waiting 3 hours between dinner and sleeping, also raising the head of the bed. Just stacking pillows will not do the trick. We want to put a foam wedge under the mattress or prop up the legs of the head of the bed with wooden blocks. Exercise is often an overlooked intervention for many of these GI issues. As long as we're using those voluntary muscles, we can also get benefit for the involuntary muscles of the gastrointestinal tract. So we've seen that exercise plans can benefit reflux, as well as the stress benefits that from exercise that assist with managing these symptoms. This is a resource taken from Heather's IBS cheat sheet that I tend to overuse because I just find it's really useful for a lot of these, for kind of simplifying a lot of these interventions. So let's review those reflux recs. Avoiding chocolate, avoiding alcohol, peppermint, caffeine, acidic foods, tomato and coffee kind of fall under that category, as well as all high-fat foods and high-fiber foods can exacerbate reflux symptoms. We have another poll, but I'm going to go ahead and skip it. Gastroparesis. So here we've moved down the esophagus into the stomach. Gastroparesis is really defined as delayed gastric emptying. I was surprised to see the prevalence of this condition, according to UpToDate, is only 0.2% of the population. I feel like we get a lot more folks suffering with gastroparesis in clinic, but maybe that's just because we have a skewed population with nutrition and diabetes. The symptoms associated, a lot of nausea and vomiting, early satiety, being full after 3 bites of food, and the associated bloating and abdominal pain that can come along with it. Usually, what's the cause of gastroparesis? Generally, it's idiopathic, which is the scientific way of saying, I don't know. But it also may be a complication of diabetes from the nerve damage. It can happen from elevated blood sugars. Also, people with surgeries like a Roux-en-Y or Bill-Roth Whipple surgeries can cause damage to some of those nerves and result in gastroparesis. We also had a question from a very proactive participant about methadone and its effects on the gut. And gastroparesis is certainly one of those issues that can be exacerbated by any opiates or narcotics. Because its effect is to inhibit those neurons that are so crucial for moving things down the gut. To properly diagnose gastroparesis, first of all, we want to make sure that it's not because of some obstruction down here in the lower stomach. We want to rule that out first, but then a gastric emptying study will confirm this diagnosis. And we have this image here that shows the result of somebody's gastric emptying study. This study involves taking an egg salad sandwich or a tuna sandwich, whatever your preference, sprinkled with a small amount of radioactive chemical. And that allows us to see these the neon colors of where that egg salad sandwich has gone. It's a 4-hour test. It's totally normal to still have most of that meal in the stomach after 1 hour. But if we still have some food left after 4 hours, that could indicate gastroparesis. Just for comparison, somebody with severe gastroparesis might have a third of that sandwich left in their stomach after the 4 hours. For those of you that aren't into radioactive deli sandwiches, there are alternative diagnostic tools like the WMC capsule, which is the wireless motility capsule. That was something I learned, as well as the spirulina 13C breath test. Either of those can be help to diagnose gastroparesis as well. Moving on to the treatments, we do have medications to help with this condition. The prokinetics, including Reglan and Motilium. For those with nausea or vomiting, that's pretty severe. Zofran can help to relieve that symptom. For those with really severe gastroparesis, there's some more invasive procedures like the gastric electrical stimulation, where they simply place an electrical stimulator on the stomach to give those neurons a little jump start. There's also the G-POEM, which is a myotomy that occurs at the pyloric sphincter. It's where they cut and remove some of the muscles to sort of open up that exit. The nutritional recommendations, as you may be familiar, avoid fatty, spicy, and high fiber roughage, as well as carbonation. Alcohol and smoking can also inhibit the nerves, so it can worsen gastroparesis. And for people in clinic with more severe symptoms, we might build a nutrition plan based on blenderized foods. So making a whole variety of delicious smoothies, soups, and shakes to get your nutrition needs met. Of course, for those with diabetes, very important to include control the blood sugars so that we can prevent any further nerve damage. So going back to Heather's IBS cheat sheet, the recommendations for gastroparesis are to avoid fatty foods, spicy foods, alcohol, carbonation, and roughage, this whole high fiber category. The Masled has been such a hot topic in recent years. It was actually renamed from non-alcoholic fatty liver disease. It now goes by metabolic dysfunction associated steatotic liver disease. We can call it Masled, first name basis. So the prevalence was way more common than I was expecting to see. Apparently 30% of people worldwide have some degree of this fatty liver. And that could be because many of them aren't experiencing symptoms. If it's more severe, fatigue and discomfort are possible. Oh, let's show where this is happening. The liver. The Masled definitely goes hand in hand with all of those insulin resistance related conditions, high blood pressure and cholesterol, but also oxidative stress and genetic factors play a pretty significant role here too. Let's see, to diagnose Masled, it just takes imaging, but we also want to see, well, we don't like to see this, but to confirm the diagnosis, an elevated ALT, which is a liver enzyme that's released when it's under stress. Also, just the general clinical presentation has to make sense for this diagnosis. A biopsy may be indicated if this doesn't confirm the diagnosis. Really not a lot of medical treatments directly for Masled. There are medications to treat some of the other metabolic disorders like statins to help keep the lipid profile in line. But it's also advised to prevent any additional liver damage. So be up to date on our hepatitis vaccinations. On the nutrition side, avoidance of alcohol is key here, and the physical activity always important. Vitamin E, there's been emerging research that the antioxidant value of vitamin E may have some promise, as well as omega-3s that help the liver to do its factory function properly. Really, the weight loss has been a mainstay of Masled treatment. They find that people who are able to lose 5% of their body weight actually improve their hepatic steatosis or their fatty liver. And after 6 months of intentional exercise and nutrition, we may consider just discuss bariatric surgery. Let's move over to the pancreas. Fortunately, Anatomical Tom doesn't have a pancreas shown here, but that's where it would be. Because exocrine pancreatic insufficiency, or EPI, is a fairly recent diagnosis, or kind of an under-recognized complication of pancreatic disease, we really don't know the general prevalence, but there's been some studies that show increased risk for octogenarians. Really, EPI is just simply the reduced secretion of digestive enzymes. So we're not talking about the insulin or glucagon role of the pancreas here. We're talking about the pancreas's digestive role and how it releases those enzymes. For people with EPI, they are kind of malabsorbing fats, and that can result in these light-colored or loose and greasy stools that are also foul-smelling. Fortunately, we have a biomarker by the name of fecal elastase that can confirm this diagnosis. There are pharmaceutical-grade digestive enzymes for this condition, Creon among them. For those who have been malabsorbing fats, it could also be worthwhile to invest in a vitamin supplement for fat-soluble vitamins. On the nutrition side, aiming for 4 to 6 small meals a day can only help with tolerating these symptoms. Another note I'll just mention is that you may see some of the papaya enzymes or supplements that are sold as benefit for digestion. Largely, those will be effective for people who truly have pancreatic insufficiency or something going wrong with the liver or gallbladder, but not necessarily will benefit anyone without these conditions. Let's move on to celiac disease. So very common, 1 in 10 people. That could be because 80% is undiagnosed. Many people are asymptomatic with celiac. Sometimes I'll have somebody show up in clinic with a celiac diagnosis and they say, I feel fine. It's just my doctor told me I have celiac disease. But many people will have these abdominal pain, bloating, diarrhea symptoms. The diagnosis for celiac disease is kind of twofold, and we keep a close eye on these markers as we go. So the IgA, very similar to the IgE antibodies we saw earlier with allergies. The TTG stands for the tissue transglutamase. So it's the body reacting to gluten. This is a biomarker we can see in the blood. The biopsy, oh, we can get a picture of that. The biopsy, a healthy small intestine should look like, have these folds. I think it really looks like a coral reef, a healthy coral reef. But as we increase the Marsh score, we see further and further damage to the small intestine, where celiac really has the damaging effect. We can end up with these very barren wastelands without folds with severe damage. Of course, the primary treatment for celiac disease is to completely avoid gluten or any of its code names like wheat or rye, barley, beer, and malt. It's also important to review the lotions or shampoos that could have some of those ingredients as well. Of course, there's lots of starches that are an option for us, including certified gluten-free oats. I know if they are not certified, they are likely to be contaminated. Typically, people with celiac disease will have a referral to a dietitian just to manage any potential vitamin deficiencies. It's also important for people with celiac to rule out any other autoimmune diseases because celiac can go hand in hand with type 1 or Hashimoto's or lactose intolerance. Over the course of managing celiac disease, we kind of do 6 months solid of a gluten-free diet as best as we can, and then we may check another biopsy after that. Usually the IgA, the blood draw, improves a lot quicker than the small intestine, which takes some time to get to the nice, colorful coral reef again. Here is a resource from the gluten intolerance group that shows us all the ways we can prepare these delicious gluten-free grains. Cooking instructions included. Let's go even a little further down the gut to SIBO. So according to UpToDate, they said that 90% of these cases are due to motility disorders, meaning things are not moving through as quickly as they should, or pancreatitis. The folks who have dealt with SIBO in clinic don't seem to have issues like this, but there may be some underlying motility issue going on there. I don't know. What SIBO is basically small intestinal bacteria overgrowth. Usually our friendly bacteria should be living in the large intestine, the colon, but what can happen is those sneaky critters can move into the small intestine where they're not supposed to be. And that can result in this excess fermentation, some damage to the small bowel. This is a neat picture of the breath test, which is a really cool way to diagnose SIBO. What the breath test does is detect the hydrogen or methane or potentially hydrogen sulfide that's released from those bacteria in the small intestine. And just like that, you have a confirmation of SIBO, or you find out you're in the clear. We can also go in and do a culture of the small bowel just to see if there are bacteria growing where they're not supposed to. Let's move on to treatments. Usually those with SIBO run a 2-week regimen of antibiotics. On the nutrition side, it's really important to correct deficiencies because the small bowel is really where we want to absorb most of our vitamins and minerals. So damage makes that difficult. We can also treat some of the underlying factors. The achlorhydria, correct me if I said that wrong, but basically it's the low stomach acid that can result from proton pump inhibitors like Protonix, or the dysmotility that they suggested. There's been hopeful research around low FODMAP diet, probiotics, or an elemental diet, which is kind of like a liquid broken down diet. None of those are showing, the research is still conflicting from using those to manage SIBO. Let's go to IBS. I know that came up in our poll. So IBS is really a condition that's happening in the colon here. Cardinal symptoms of IBS include the bloating and the distension. We can have pain, diarrhea, and constipation, or alternating or favoring one or the other. Really, IBS goes very hand in hand with FODMAPs, which you may or may not have heard of. Our FODMAP is just an acronym. It stands for fermentable. The O is the oligosaccharides. So long chain carbohydrates that we find in garlic, onions, Brussels sprouts, cabbage, broccoli. Also the disaccharides like lactose, monosaccharides like fructose, or polyols, the sort of sugar alcohols that can be naturally occurring in prunes or apples or pears, as well as artificially sweetened beverages. Another really interesting feature of IBS is a lot of this is really related to stress, hypersensitivity, or even hypermobility can go very much hand in hand with IBS. Really interesting, which is why I'll jump ahead. The cognitive behavioral therapy, rethinking how we think about our relationship with our gut, befriending our gut, and hypnotherapy, which could include scripts that we read through to develop a more empowering mindset about accepting the symptoms, can actually relieve symptoms. So really impressive work there. To diagnose IBS, fortunately, we have the Rome Foundation, which establishes this criteria. True IBS is uh, involves pain at least once a week for greater than 3 months. Also, we would have to see changes in stooling that would confirm that diagnosis. We'll take a little bit of a look at the low FODMAP diet on the next couple slides. That's followed by challenges. So a lot of times people feel so much better after eliminating the FODMAPs, but we encourage them to reintroduce one group at a time to see which ones are really the culprits so that we can broaden the diet as much as possible. Again, probiotic is, there's mixed research that may be in part to some of the research being a single strain of bacteria versus others may have 30 strains. Here we have a look at the various FODMAP categories. Monash University is a fantastic resource. They actually developed the low FODMAP diet and have done a lot of the research to help people feel a lot better in this condition that can really affect quality of life and allow people to live their lives again. This is an example of a chart that we can use for the FODMAP reintroduction. So here we see week 1, we're reintroducing the oligosaccharides like the onions and the black beans, trying a little more each day as long as we can tolerate it and keeping track of what the symptoms are through those days. The long weekend is a washout period before the following week to try lactose or another category. Let's move on to diverticulitis or diverticulosis. So this is a pretty common one in the Western world. I think it's because of our low fiber diet. What happens with these is it's really defined by these pouches, these outcroppings from the large intestine. It affects the same place as IBS, but it's a totally different mechanism that's happening here. Basically, without the fiber in the diet, potentially, we have the high pressure in the colon that causes these outcroppings, these diverticuli. Then we have up to a quarter of people with diverticulosis can progress to diverticulitis, which is an inflammatory condition that it can be painful and may require surgery. To diagnose this, it's usually just found on accident in a colonoscopy or any GI imaging. For those of you with diverticulosis, do keep in mind that if it's progressing to diverticulitis, if you're having worsening abdominal pain or temperature or unable to tolerate solids or liquids, then that might be a good time to go to the hospital. For those in remission who are just not having the inflammatory complications, research has established that high fiber diets can reduce the recurrence of these diverticulitis episodes. Conventionally, the medical profession recommended that we stay clear of nuts and seeds, but as Up to Date says, this belief is completely unproven. We do not suggest that patient with diverticulosis avoid seeds, corn, or nuts. So please include these high fiber foods in the diet to prevent diverticulitis. Okay, good. Here we have diarrhea, and really all of us can have loose stools at one time or another. But this is really referring to chronic diarrhea that affects 3 to 7% of the population. This can be from a variety of causes. The secretory diarrhea can be the result of infection. The osmotic is more common. That usually has to do with the food that we consume is drawing a lot of fluid and electrolytes into the colon, which causes it to flush out a lot more readily. But there's also inflammatory or steatorrhea or oily stools like we saw with the pancreas. On the diagnostic side of things, so it could be the consistency of the stool. Here we have the Bristol stool chart. Really, a type 5 to 7 could be classified as diarrhea, or greater than 3 stools a day for more than a month. Certainly, diarrhea can be the symptom that's an outcropping of many different conditions, so further testing may be required. Some of what we've seen already in our previous slides: stool sample, breath test for SIBO, the colonoscopy or imaging, or just dietary elimination. There is one medication that helps to manage diarrhea, and that's Imodium. On the nutrition end, there's lots that we can do to sort of manage this symptom, limiting those simple sugars like the FODMAP sort of foods. Also, caffeine is a stimulant and can cause things to move through a lot quicker. It can be a good idea to rely on those well-balanced, small, frequent meals. Also, avoiding certainly spicy foods can be another trigger food. In the hospital, we would see some recommendations for a BRAT diet, which just stands for bananas, rice, applesauce, and toast. But with that in mind, I want to take your BRAT to the next level. So we finally complete the Heather's IBS cheat sheet with the soluble fibers, the foods that are easy to digest. The gut appreciates these easy carbohydrates. Granted, these are high carb foods, so can cause an increase in blood sugar, but we really just want a small portion of soluble fibers with most meals, and the gut will thank you. Let's finally go to constipation. Save the busiest slide for last. This UpToDate said it was the most common digestive complaint, but then they say it's only 12 to 19%. Guess that's neither here nor there. Usually constipation is related to normal transit, but it could be a low motility issue, like we kind of alluded to before, like slow transit constipation. It could also be an outlet issue, which really is resolved with the pelvic floor exercises with a physical therapist. So there is methadone coming up again, where any nerve injury can worsen constipation. So certainly the opioid use, anesthesia, surgery, spine issues can reduce the nerve function. To diagnose constipation, we have the Rome criteria again. So that'd have to be more than 3 months of at least 2 of these symptoms. There again is the Bristol stool score, which would really just be the 1 or 2 end of the scale, or less than 3 bowel movements per week. Here's a fun fact. If you take your weight in pounds and divide it by 21, you can determine your cups of water per day. We don't have to go overboard on the water, just get at least that amount, and that should help to stave off the constipation. The water, as well as the fiber, being very gradual about your fiber intake, maybe 5 new grams of fiber each week. Wheat bran is one of the most tried and true nutritional remedies for constipation. Just doing it 2 to 6 tablespoons each meal with water, also adding gradually, can really alleviate these symptoms. It's also important to include some of those sugar alcohols or the FODMAP foods, where that will help with that osmotic effect and draw fluid into the colon to help things move a bit smoother, which is why prunes is such a high source of sorbitol, as well as apple, pear, and cherry. We have a whole slew of medication options for constipation, everywhere from just our bulk laxatives, the Metamucil or Benefiber. Psyllium husk is kind of one of the more tried and true bulk laxatives. Keep in mind that if it is that uncommon slow transit or low motility constipation, we would not want the bulk laxatives because they can cause more of the bloating and discomfort. Then we have osmotic agents that draw that fluid into the colon. That could be Miralax or milk of magnesia. Then we have the stimulant laxatives that should just be used on a short-term basis because they are really putting a fire under those nerve pathways to move things along. So at long last, why don't we look at things that just generally help? It can't hurt to get a well-balanced diet of protein, grains, and fruits and vegetables, whatever that looks like for you. Getting 3 to 6 small meals per day at regular times can be a good idea. I know a lot of people are trying to reduce the amount of their eating window, but even if we're just down to a 6-hour eating window during the day, it's important to eat a few times in that area. Of course, we talked about gradually increasing fiber. Women are recommended to get 25 grams of fiber per day. Men are recommended to get 38 grams. The national average is about 11, and the recommendation may not even be optimal. Our ancestors and potentially our great-grandparents were getting something like 50 to 75 grams a day, so be gradually including that fiber. We didn't hit probiotics directly, but if you have any, if there's any reason you can't include probiotic foods in the diet, you may consider a 1-month trial of a multi-strain probiotic, something with a whole variety of bacteria. We mentioned those soluble fibers can be our friends, definitely getting the recommendations of exercise, as well as stress management really helps with the, as we saw with IBS or reflux. Important to follow up with your primary care provider at regular intervals so that they could refer you as needed to a dietitian. Speaking of, our Department of Dietitian, Diabetes Educators, and Wellness Coaches have all these upcoming events. Please stay tuned. We'll have a wellness webinar just like this next month on PCOS. Jessica Douglas will be taking us through that one. We also have a weight management program, blood pressure, quitting tobacco for good, and the InBody 570 to get a better sense of your metabolism.
Okay, great. Thank you, Riley. That's very helpful, wonderful information. Thanks for being here to share that with us. We could add on here like meeting with a dietitian like yourself. We have appointments for those that you can speak with your doctor about getting a referral for one-on-ones with some of our dietitians to kind of work through some of these things that Riley, you've been talking about today as well. I have one question in the chat here for you in this Q&A, and then if anyone else has any other questions, feel free to throw those in the Q&A or in the chat as well. But Riley, this one is about soluble and insoluble fiber. Can you just elaborate on that a little bit more, like the differences between the two?
Sometimes I wish we could have a 3-hour session because I could talk about soluble and insoluble fibers all day. I think this is a good representation. So soluble fibers are basically going to absorb water when they're in the GI tract. They help to bulk up the stool. Psyllium husk, like Metamucil, is that right? Is also a bulking agent, and psyllium husk is really just a soluble fiber. Insoluble fibers can be a little bit more harsh on the gut, so we want to be gradual with adding these. Sometimes it's a little overly simplified, but sometimes I'll call soluble fibers a little bit of a brake. It slows things down, and insoluble fibers are kind of an accelerator pedal. They sort of speed things up through the gut.
Great. Got another question in the chat here for you. Do you have a multi-strain probiotic that you would recommend, like any brands?
Oh, I wish one of the companies would pay me enough to recommend one product over another. I'm just kidding. I do have a handout that I could send over to Erica and Erica, if you could distribute it. Basically, it looks at the nutrition label for a single strain or maybe duo strain probiotic, which is just two bacteria um, and two types of bacteria, versus like a 30 or 40, maybe even 50 strain probiotic, which is basically a whole ecosystem of bacteria that you're introducing to the gut. So I think that those ones show more promise.
Okay. Thanks, Riley. Those are the only questions that I'm seeing in here. So I think we are good to go. Again, thank you all for attending today. We really appreciate you taking your time to be here with us. This is recorded, so we will send out a recording of this if you want to go back and watch it later, get some more information from Riley. Oh, and I've got one more, Riley, as I'm talking. Can some of those probiotics be prescribed?
I'd have to look into that. I think you stumped the RD here. I'm curious about like I don't know what we have for insurance, like various private insurance plans that would cover those. I have seen them in medication lists, so technically they can be prescribed, but whether they be covered, I'm not sure about that.
Right. There's a couple questions in here about where you can get a copy of the cheat sheet or kind of getting a list. Riley will send that over to us and we will make sure it goes out to you in an email when you get the recording of this. Now, if you have other questions, you can email us at wellness.wa@providence.org and we'll get those questions answered from Riley. Otherwise, we'll put everything in that email, these cheat sheets and the resources that he's been talking about today. Right. Otherwise, thank you all so much. Thanks again, Riley, for being here and giving us some good information.
Thank you all for sticking with me on that sprint.